Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very precious tips which may prove handy in your line of duty. So I welcome you to Part 85 of our Pharmacotherapy MCQ series, Majoring in Oncology. And the first question reads, which of the side effects listed below would be experienced by patients receiving MESNA in the course of cancer treatment? Is it hemorrhagic cystitis, false positive ketone tests, neurotoxicity, or hyponatremia? I'll give you 10 seconds to choose the correct answer. Experience false positive ketone tests. I would just like to mention that MESNA is used in the prevention of hemorrhagic cystitis associated with ifosfamide injection or administration, and it may cause a false positive test for urinary ketones. Let's move to the next question, please. And it reads, which neurotransmitter pathway is majorly involved in the case of a middle-aged cancer patient undergoing treatment who experiences acute emesis from the chemotherapy infused during his cycles of treatment? Is it substance P, serotonin, acetylcholine, or is it dopamine? I'll give you 10 seconds to choose the correct answer. Serotonin it is. I would just like to start off by saying that during acute emesis phase, which is within 24 hours after chemotherapy, the primary neurotransmitter serotonin is released from the enterochromaffin cells in the gastrointestinal site and also within the brain. Substance P, which is alternative A, is primarily released in delayed phase of emesis, which is anywhere from 24 hours to 120 hours after chemotherapy. Then I would like to add that dopamine is released throughout the different phases of emesis. However, the use of dopamine blockers or antagonists such as prochlorperazine and haloperidol is less effective in preventing emesis than the use of, for example, the 5-HT3 receptor antagonists like ondansetron, granisetron, valonosetron, and so on and so forth. I would like to add that acetylcholine has a very limited role in chemotherapy-induced emesis. So all those many words make alternative B, serotonin, the best choice. Let's move to the next question, please. And the next question reads, which of the medications listed below antagonizes chemokine receptor 4 binding to stromal-derived factor 1 on the bone marrow stromal cells, thereby allowing for an increase in the amount of peripheral progenitor cells? Is it the ipilimumab, marketed as Yervoy, or is it sagramostim, marketed as Leukine, or is it Plerixafor, marketed as Mozobil, or is it filgrastim, marketed as Neupogen? I'll give you 10 seconds to choose the correct answer. So plerixafor or mozobel it is. Now I'd like to start by saying that filgrastim or Neupogen and sagramostim leucine are both colony stimulating factors which are designed primarily to increase the production, maturation, and activation of neutrophils. Now ipilimumab, which is Yervoy, is a monoclonal antibody designed to bind to cytotoxic T lymphocytic associated antigen 4, thereby allowing for T cell activation. And plerixafor, which is mozobel, is a combination product. It's combined usually or complexed with zinc and is approved for the mobilization of progenitor stem cells. That is the mechanism by which it works. All those many words justify why C is our correct answer. Let's move to the next question, please. And it reads, which of the medications listed below can be used in the management of CML and should only be taken on an empty stomach? Is it hydroxyurea, dasatinib, nilotinib, or imatinib? I'll give you 10 seconds to choose the correct answer. So nilotinib it is. I would like to start by saying that imatinib or Glivec should be administered with a meal and a large glass of water. It's specified in the literature insert. And dasatinib or Sprycel may be taken without regard to meals, although taking it with meals decreases nausea. And then nilotinib, which is marketed as Tasigna, should be taken on an empty stomach only. It's emphasized in literature, so that makes answer C the correct one. Let's move to the next question, please. And it reads, Mr. TBT, a 68-year-old male patient with metastatic colorectal cancer, receives bevacizumab alongside Folfox at your oncology clinic. And after receiving his third cycle, Mr. TBT is admitted following a PE. And on recovering, he is discharged home with a prescription for dalteparin. He returns to the clinic for additional chemotherapy. So my question to you is, should Mr. TBT continue receiving bevacizumab therapy, and which is the best option for him now? Would it be A, since TBT has developed a VTE while on chemotherapy and bevacizumab, his colorectal cancer has progressed and therefore we should discontinue bevacizumab? Or is it true that bevacizumab shouldn't be restarted since patients on bevacizumab have a higher risk of recurrent VTE and a higher risk of bleeding with concomitant anticoagulation and bevacizumab as compared to those without bevacizumab? Or is it true that bevacizumab may have been the cause of VTE, however, the patient is receiving dalteparin, so the risk of recurrence is minimized, therefore we should restart bevacizumab? Or is it true that Mr. TBT developed a VTE which isn't associated with bevacizumab, and bevacizumab causes arterioembolic events, so bevacizumab should be restarted in Mr. TBT's case? So I'll give you 10 seconds to choose the correct answer. So B is correct, and the reason why is that in a study involving around 1,400 metastatic colorectal cancer patients, VTE was present more in the bevacizumab arm. That was 13.5% versus 9.6%. Now, over 100 patients were treated with anticoagulation following the initial VTE, and the overall incidence of subsequent VTEs was higher in the bevacizumab arm. That was 31% versus 25.6%. And the overall incidence of bleeding was higher in the bevacizumab arm, which was 27.4% versus 20.9%. And now, basing on the information above, bevacizumab, in my opinion, should be withheld due to increased risk of VTE and even bleeding. Let's move to the next question, please. And it reads, imatinib was the first tyrosine kinase inhibitor, what we abbreviate as TKI, to be approved in the United States of America in 2001 against BCR-ABL for the treatment of chronic myelogenous leukemia, CML. Many TKIs have since been approved for the treatment of various cancers, and they are different in that they inhibit multiple TKs, that is tyrosine kinases. So my question to you is, which of the statements below is true regarding multi-targeted TKIs? Is it true that they may be taken without regard to meals? Is it true that they may be more effective against some resistant tumors? Is it true that they are unaffected by CYP450 enzyme systems? Or is it true that the associated toxicities may be less than other agents? I'll give you 10 seconds to choose the correct answer. B is the correct answer. They may be more effective against some resistant tumors. Now, I would just like to start by saying that cancer is associated with multiple pathophysiologic mechanisms. Therefore, in my opinion, targeting the tumor through inhibition of multiple pathways may provide better clinical outcomes. A good example is sunitinib, which has been effective in the treatment of gastrointestinal stromal tumor, what is abbreviated as GIST, after imatinib failure. Now, as targeted agents inhibit multiple TKI activities, there is an increased risk of toxicities, and that makes answer D wrong. I would just like to add that multi-targeted TKIs such as sunitinib, lapatinib, and sorafenib have CYP450 drug-drug interactions, making C wrong. And meals can also affect the PK/PD of these agents, including sorafenib and lapatinib. Remember, sunitinib was the first drug to show clinical benefit in imatinib-resistant GIST. Now, resistance to sunitinib, however, may generally be developed within a year, so it can help you buy some time. And I would like to remind you that in patients with GIST who have developed resistance to imatinib and sunitinib, regorafenib, which is a newer agent, has been shown to improve progression-free survival compared to placebo. Just as a by the way, let's move to the next question, please. And it reads, prior to recommending hormonal therapy, clinicians should consider the adverse drug effect profiles of aromatase inhibitors and tamoxifen. My question to you is, which of the adverse drug effects listed below are more associated with aromatase inhibitors than with tamoxifen? Is it hot flashes and endometrial cancer? Or is it osteoporosis and arthralgia or myalgia? Or is it endometrial cancer and osteoporosis? Or is it arthralgia or myalgia and thrombosis? I'll give you 10 seconds to choose the correct answer. So it is osteoporosis and arthralgia or myalgia. Now, both tamoxifen and the aromatase inhibitors contribute to hot flashes, night sweats, and they may even cause vaginal dryness. I would just like to add that the aromatase inhibitors are more commonly associated with arthralgia or myalgia and even osteoporosis and an increased risk of bone fractures, whereas tamoxifen is associated with an increased risk of uterine cancers and even thrombosis. I would like to add that supportive care for women on adjuvant endocrine treatments includes management of hot flashes and even depression that may occur. And then concomitant use of tamoxifen and certain SSRIs, which happen to be strong CYP2D6 inhibitors such as paroxetine, fluoxetine, may decrease the levels of the active metabolites of tamoxifen, and that can lead to treatment failure. Therefore, venlafaxine, which is a milder CYP2D6 inhibitor, can be used as an effective treatment for hot flashes instead. Let's move to the next question. And it reads, which of the following is the main method of carboplatin elimination from the body? Is it hydrolysis? Is it via the fecal route? Is it hepatic? Or is it renal? I'll give you 10 seconds to choose the correct answer. Renal route is the correct answer. And approximately 70% of administered carboplatin will be excreted and changed in the urine over a 24-hour period. And it needs to be dose adjusted in cases of renal impairment, just as a reminder. And it is the only chemotherapeutic agent dosed using what we call the Calvert formula, which takes into account renal function. I'd just like to remind you that the Calvert formula, according to that formula, the dose in milligrams is equal to the area under the curve times GFR plus 25. Now, the FDA recommends using glomerular filtration rate of no more than 125 ml per minute to avoid overdosing the carboplatin and causing toxicity. So be very careful when you are dosing these patients. I would also like to add that typically carboplatin's area under the curve changes from 3 to 7 milligrams per ml per minute, just for your information. Let's move to the next question, please. And it reads, Mr. KYJ, a 47-year-old male with confirmed Burkitt's lymphoma, which was diagnosed recently, presents to your oncology clinic 3 days into receiving his hyper-CVAD therapy, which is cyclophosphamide, vincristine, doxorubicin, and dexamethasone. The oncology nurse noted a decreased urinary output. Some of his pertinent lab results include a BUN of 22, serum creatinine of 1.6, uric acid levels of 14.5 milligrams per deciliter, phosphate levels of 4.4 milligrams per deciliter. The potassium levels were 4.6 milliequivalents per liter. So my question to you is, which of the agents listed below should be started immediately in the case of Mr. KYG? Should you initiate probenecid, rasburicase, allopurinol, or should you administer IV fluids with sodium bicarbonate? I'll give you 10 seconds to choose the correct answer. Would initiate rasburicase. Now, I would like to start by saying that allopurinol prevents the formation of uric acid, so it doesn't have any influence on the uric acid that is already circulating. Now, the only agent that will have a significant impact on uric acid levels in this list is rasburicase. And as uricase rapidly converts uric acid to allantoin, which is readily eliminated renally via urine, it should be considered when patients have an elevated uric acid plus an altered renal clearance, most likely due to uric acid nephropathy, like in this particular case. Now, probenecid alternative A prevents the reabsorption of uric acid at the proximal convoluted tubule, which allows renal elimination of excess uric acid. Now, this drug isn't used for elevated uric acid levels from tumor lysis syndrome. I would like to add that the use of sodium bicarbonate to alkalinize urine is currently not recommended for the prevention and treatment of TLS, tumor lysis syndrome, due to the complications of metabolic alkalosis and even calcium phosphate precipitation, as well as the lack of evidence demonstrating any benefits. Now, remember, all patients at intermediate or high risks for TLS, tumor lysis syndrome, with the exception of those with renal failure or oliguria, should be adequately hydrated for the prevention and treatment of tumor lysis syndrome. Just as a by the way, let's move to the next question, please. And it reads, Mrs. HGP, a 64-year-old white female patient with suspected leukemia, is admitted to your hemato-oncology ward. Some of our pertinent lab results include a WBC of 722, HB of 8.1, hematocrit of 24.7, the platelets are 333, sodium levels are 142, the potassium level is 4.6 milliequivalents per liter, chloride levels are 106, CO2 of 26, creatinine of 1.34, phosphate levels of 5.8, and the uric acid levels are 1.29, and the LDH is 1933 with the calcium level of 9.6. Her chief complaints include a weight loss over the past 6 months, half a year, with occasional fevers at night. She doesn't complain of fatigue or dyspnea on exertion. Cytogenetics of peripheral blood demonstrate what we call a T9:22. So my question to you is, which of the diseases listed below is usually associated with this chromosomal abnormality? Is it acute promyelocytic leukemia? Is it chronic myelogenous leukemia? Is it chronic lymphocytic leukemia? Or is it plasma cell leukemia? I'll give you 10 seconds to choose the correct answer. So CML it is. Now with CML, the translocation at chromosome 9 and 22 allows the breakpoint cluster region, which is abbreviated as BCR gene, from chromosome 22 to be switched and fused with the what we call the Abelson, ABELSON, murine leukemia, abbreviated as ABL gene, on chromosome 9. I'll repeat that. With chronic CML, the translocation at chromosomes 9 and 22 allows the breakpoint cluster region, BCR, the gene involved there, from chromosome 22 to be switched and fused with the ABL gene on chromosome 9. Now the new fission product, which is a BCR-ABL gene, allows this tyrosine kinase to be active and to allow cells to grow unrelentlessly. That explains why B is a correct answer. Let's move to the next question, please. And it reads, Mrs. EFT, a 56-year-old postmenopausal female patient, has biopsy-proven endometrial serous carcinoma, which is considered high grade. She undergoes surgical staging with a total abdominal hysterectomy, abbreviated as TAH, together with a BSO with lymph node dissection. She is found to have a stage 4B disease with peritoneal involvement. She has what we call an ECOG score of 0, and currently she takes metformin, lisinopril, fluoxetine. So my question to you is, which of the treatments listed below would be the most appropriate for Mrs. EFT now? Would it be tamoxifen, or would you co-administer cisplatin, doxorubicin and paclitaxel, or would you co-administer carboplatin and paclitaxel, or would you administer monotherapy cisplatin? I'll give you 10 seconds to choose the correct regimen. I would opt for carboplatin alongside paclitaxel. Now, carboplatin and paclitaxel is the preferred treatment for advanced or metastatic or even recurrent endometrial cancer. A phase 3 study comparing this regimen versus cisplatin, doxorubicin and paclitaxel plus filgrastim showed similar outcomes but improved tolerability and toxicity with carboplatin co-administered with paclitaxel. I'd just like to add that combination therapy regimens have higher response rates and are preferred over single agent options such as D if they are tolerated. So I would not opt for D. I would just like to add that single agent treatment options include but aren't limited to cisplatin alone, carboplatin alone, paclitaxel alone, or doxorubicin alone. And I would like to emphasize that 3 drug regimens such as doxorubicin, cisplatin and paclitaxel isn't commonly used due to its significant toxicities, which include, for example, peripheral neuropathy. Then I would just like to emphasize that clear cell and serous carcinomas are often hormone receptor negative. Therefore, hormonal therapies should only be used in low-grade endometrial histologies, which are not grade 3 endometrioid, serous carcinomas, clear cell carcinomas, or even carcinosarcomas. Now, tamoxifen isn't applicable in this case. And for metastatic, recurrent, or high-risk disease, a combination therapy regimen is recommended over single agent regimen. I'm just re-emphasizing if tolerated due to its improved toxicity profile. Now, I would like to remind you that carboplatin and paclitaxel remains the preferred regimen from that list of 4, and hormonal therapies should only be used in lower grade endometrial cancers. And then I would just like to emphasize that endometrial serous carcinomas account for like 10% of all endometrial cancers, and it happens to have the poorest prognosis with 5-year survival rates as low as 55%. So they should be treated with the seriousness they deserve. So my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to remind you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. I thank you very much for viewing this video and for listening to me, and I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And and I look forward to interacting with you in the next video. Thank you.